with Newsfeed. Thanks for being with us this afternoon. The Health Minister, Dr Joe Paahla, confirming today that children and teenagers from the age of 12 will now be able to get a COVID-19 vaccination from Wednesday. But they'll get a single Pfizer shot. They'll only be able to get that shot and not the second Pfizer shot at this stage. Professor Mosa Moshabela, Associate Professor, Acting Deputy Vice Chancellor of Research and Innovation at the University of KwaZulu-Natal. Professor Moshabela, I really appreciate the time. Good afternoon and thank you. The obvious question to ask is, why do people between the age of 12 and 17 only get the one Pfizer jab and not the second one?
Yeah, good afternoon to you, Stephen, and to the viewers. It's a very important question, and I think that in the briefing this morning, there could have been a little bit of more discussion around that to clarify it. But when we look at the evidence currently in terms of vaccines, we've got quite a good amount of evidence from the US and more recently quite a good amount of evidence from the UK. And we have seen from the UK that actually they are the ones that weighed the balance of the evidence. And even though the decision to actually for them to focus on the one dose of Pfizer was very marginal and balanced, they decided on that on the basis of weighing the benefits and the risks. So after one dose of Pfizer, there is a lot more benefit to the age cohort of 12 to 17 and minimal risk. But after the second dose, the benefit reduces, it's minimal, and the risk starts to increase. So that's why when they looked at it, they were like, well, let's stick with one dose instead of going for the second dose. And that's not necessarily what the US is doing. The US is actually going with two doses 3 weeks apart. And they've also documented that there is a little bit of an increased risk of myocarditis, the inflammation of the muscle of the heart. It's also very rare. I mean, it's about 60 in a million after 2 doses in young boys and about 8 in a million in girls. And in most instances, they present with a pounding heart and a little bit of a chest pain, but it resolves on its own. So really, Stephen, it is about this constant effort to try and balance the maximum benefit and try and find the minimum risk in these decisions.
I would imagine that different people might come to sort of different balances. I mean,
yes.
Do you think we came to the right one? Are you worried about the balance we've struck?
Yeah, no, I think, you are absolutely right. That is really indeed that the argument can be strong in both sides, and it's really a fine balancing, especially the lower you go in age, because children are able to really stimulate a strong immune system. And part of the explanation for this rare event of myocarditis, especially in young boys, has got to do with the immune system that they generate. And so I think that in South Africa, we seem to have aligned more with the UK policy rather than the US policy. And I think it's a good decision. I just think that it needs to be communicated better because it sort of deviates from what we have known up until this point and what we have done up until this point. And some people are asking, okay, then if we want to go with one dose, why are we not using Johnson & Johnson? And the point there really is the fact that Pfizer is the only one that is so far approved for children between 12, teenagers between 12 and 17. It's the only vaccine that's available. And also the other decision, Stephen, is about if the risk is so low, why do we still need to vaccinate these children? And that has to do with the fact that there is a lot more benefit beyond just looking at the individual benefit. There is a lot of benefit from preventing any potential risks for children who might have comorbidities or might have long COVID or severe disease, especially when they're still young, because that impact can be long-term in their lives. Secondly, it helps in terms of protecting people in their households or the elders in their households and preventing outbreaks in schools and things like that. So there is a broader benefit that we have to look at. So I think those things, Stephen, have to be articulated a little bit more so that South Africans can understand.
Well, I was going to come to this. I mean, we want community immunity. In other words, we want to make sure that a high percentage of our population, we've been talking about the adult population up until now, is actually vaccinated. We suddenly realize as you talk how important it is to make sure that younger people are vaccinated too for the same reason. They've got to be a part of it.
Yeah, they are. And you see, that's why you sometimes we look at young people as if they're just children and they're not part of the population. And actually they are. And they are not small adults. They are individuals as well in their own right, which is why we have to really look at the science that applies to them in their age group, not necessarily duplicate what happens with adults, and not necessarily assess their risk in comparison with people who are 60 and above, where, for example, the risk of death from COVID is much higher than in these children. But if you're looking at what happens to children and the impact COVID can have in children, for a child, that's going to be very significant for them. Yes, it's fewer of them, but we don't know who is going to be affected. And when they are affected, we don't know how severe, and we don't know how long they can stay with the consequences. But for a child, that can limit their development as they grow up. So the severity and the impact can be quite severe for a child compared to even an adult. But my argument here is that let's try and look at that category, that age cohort in their own right, and not necessarily try and say that, because their risk is lower than older adults, then they don't need to be included, or they don't need to participate in the COVID vaccination program. If the opportunity allows and the resources allow and the benefits are there and they outweigh the risks.
We've spoken in the past, Professor, about the Cyanobac vaccine. And in fact, I think there's actually a trial of the Cyanobac vaccine that South African children, so people under the age of 12, are participating in. Could it be that in the end the Cyanobac vaccine is actually a better vaccine than one jab of the Pfizer vaccine for children?
So in South Africa, the Cyanobac vaccine is being tested for children 6 months and above, 6 months to 17 years of age. As we have indicated, we don't really have strong evidence for the large, broad base of vaccines in terms of what happens in children, including in these teenagers between 12 and 17. So there's still a lot of work to be done in generating that evidence. So my own view is that South Africa is actually in a good position to consider the option of Cyanovac and how it can be used. And we have seen that Cyanovac didn't perform very well for older adults, but it seems to do well for children. And perhaps that is the right vaccine for children. And so we have to see, and it's a different kind of vaccine. It's a more traditional technology in terms of the types of vaccines. So for me, I think it's really exciting that we are doing that. It's one of the reasons why I think, the current policy to vaccinate children between 12 and 17 is really good, especially children who have comorbidities or risks of any kind. It's really good. And choosing one dose of Pfizer is also a very responsible decision. But I do think that there's a need to make sure that, we explore the opportunities and the timing of when to do this. And when the evidence emerges on Cyanovac, and I hope it comes out soon, then we need to review these decisions and make sure that we are constantly giving these children more benefits and keeping the risks really low.
It's one of these situations where for a very long time, I probably had the same vaccine that my children probably got for diseases like polio and the MMR vaccine. There would have been some changes, but it would have been roughly the same sort of thing. That's not going to happen with COVID-19. The vaccine that we get now is probably going to be quite different to the vaccine that we give people in 10 years' time because of how much research is being done.
Yeah, absolutely. And I think that we also have to come to terms with the fact that this is going to be a new way of vaccinology going forward. We are going to begin to see a lot more vaccines being developed, being improved upon, technology being advanced. We are, now at the cutting edge of vaccine research. And we need to make sure, which is also why, South Africa and the continent is also positioning itself to ensure that we're positioning ourselves to ensure that we can also manufacture vaccines and test them here that are appropriate to the conditions that we have on the continent. It's exactly because of that there is now, it's a turning point. Things are not going to be the way that they used to be in the 20th century. We have entered a new century of vaccine research and vaccinology in the 21st century, and it's not going to be the same again, and we must really learn to come to terms with that.
You spoke about if for young people, so between the ages of 12 and 17, have a very slight chance of a side effect from the second Pfizer jab. And you mentioned that it seemed much more likely in boys than in girls. Why is that? I mean, I thought immune responses were roughly the same.
Well, I mean, it comes back to the point I was explaining earlier, that I think that it's so important that we look at the evidence. I think so far we know it's related to the immune system. We know that it's slightly more common in boys than in girls. And after the second dose, it looks like it's about, the risk is about 6 to 8 times more in boys than in girls. As to exactly what the mechanism is that makes boys more susceptible, I don't know. And I don't think anyone has been able to explain it adequately. But it's similar to what we observed before. You'd remember that when we saw the blood clots, they were more common in younger females. And somehow, they had a more of a predilection to get that side effect compared to men, compared to older people. So it does happen that some of these reactions may be predisposed because of certain demographic factors or some other kinds of factors that, as we dig deeper and science continues, we'll be able to understand. But for now, I think that we just know that it's related to the immune response and how it's generated. There may be other factors that are involved that we are not yet aware of, but we'll keep the eye out and be on the lookout for why that is the case and how to intervene.
Some things are what they are until science tells us what they are. I wonder, so, I mean, all of this for younger people, I mean, it's very good news. I think it's important news. And we're likely to see, a sort of group of people, the sort of early vaccine adopters, if I can call them that, the early vaxxers, let me give them a name. They'll be going, quite quickly to go and get their young people vaccinated. We still have a lot of vaccine hesitancy around. We still are not getting to 300,000 people a day. Christmas is coming. Unfortunately, many people tell us so is a fourth wave. I mean, do we need to start panicking yet?
In my view, I don't think that panic is going to help us. I think that what we need to do is really think about strategies to drive up vaccination. And I must say, Stephen, the progress in this country is not too bad. We have come a long way. I really think that we have made a lot of progress to be at about 35% people vaccinated. Going towards 30% of people fully vaccinated. It's a huge, huge milestone. And many times, of course, we compare ourselves with developed countries, but we've got so many other limitations compared to them. On the continent, except for the small islands, it's only really Morocco that's really steaming ahead, over 50% fully vaccinated. But, we are right there behind them and we're doing well. I just think that, unfortunately, as you say, the limitation here is time. We don't have a lot of time. We need to have a sense of urgency in order to limit any sort of negative impacts that may come, be it because of variants or be it because of hospitalization and deaths. We want to limit that as soon as possible. So we're feeling the time pressure, but I don't necessarily think that in itself it spells out poor progress. This is one of the things that we have done well in South Africa in a long time, and we have to recognize that. But I agree that, we've got to find strategies to ensure that we get better at getting people vaccinated. And we cannot do 1 weekend, 2 days of Vuma vaccination drive and leave it at that. We have got to do that regularly because people really are inspired by that kind of encouragement. and participation of leaders across the political spectrum. And we haven't really seen that in a strong way. So I agree with you that, we've got to keep pushing. We've got to have a sense of urgency, but also I think we need to be empathetic to all the challenges that people are faced with.
Perhaps we can see that campaigning works because politicians are campaigning all over the country. The same may be true for vaccinations. Professor Moshabela, I really appreciate the time. Thank you. Associate Professor, Acting Deputy Vice Chancellor for Research and Innovation at the University of KwaZulu-Natal.